So we are live, I can start.
Yeah.
A very good evening to everyone. On behalf of MOGS Foxy and the conveners of this program, I welcome you all to Respectful Abortion Care CME. It is a unique endeavor of Foxy and MOGS to sensitize gynacs across the nation on safe abortion practices. Dr. Shanta Kumari, president of Foxy in her year, has championed for various women issues like DIRA, violence against women, and respectful abortion and respectful maternal care. And this program is an initiative of the same. I would like to welcome our president, Dr. Sarita Bhalerao ma'am, who needs no introduction to this august audience. She is a senior consultant at prominent hospitals in South Mumbai. She is the immediate past president of the AMWI Mumbai branch and the past chapter secretary of the IMS Mumbai chapter and a member of governing council of ICOG. We welcome you, ma'am, to say a few words.
Thank you, Riddhi. And it's wonderful to see you all here, respected Dr. Shanta Kumari, Dr. Madhuri Patel. I'm very happy that MOGS is doing this program. It's nice to see Mr. Ajay Bharadwaj here. We have worked together. And it's also nice to see Dr. Pratik, Dr. Mpa Injections, Dr. Lakshmi Shikhande, and Dr. Riddhi and all the other participants. So I think that the abortion care is a very, very important part of the armamentarium of a gynecologist. And I'm so happy that you've taken this initiative to organize this program. I really wish the program all the very best. I do understand that Dr. Krishna Kumari is going to be talking on safe abortion, and I welcome Madam. And then we have Dr. Kiran Mai, who will talk on the WHO Saver Toolkit, and we'll have Dr. Lakshmi Shikhande talk on pre and post-abortion family planning counseling. So it's going to be a wonderful evening, and all the very best. Thank you.
Thank you so much, ma'am. Without any further ado, we'll start our talks. And for this session, I would like to welcome our esteemed chairpersons, Dr. Pratik Tambe and Dr. Amay Purandare. It is my privilege to be introducing my mentors. Dr. Pratik Tambe is a chairperson of AMOG's Endocrinology Committee, governing council member of the ICOG, executive committee member of ESAR, and managing council member and patron of MOGS. He's an academician with multiple publications, and he's been awarded with various awards. And now I'd like to welcome Dr. Amay Purandare. Sir is a senior consultant at prominent hospitals in South Mumbai. He is the second vice president-elect AMOGS and joint secretary of Foxy in 2019. He was the chairperson of Food, Drugs, Medical, Surgical Equipment Committee of Foxy in 2015, and he is a member of Managing Committee and mentor of the Youth Council. We welcome you both.
Thank you, Riddhi, for all the hard work in the background, and let me express my gratitude to our MOGS president, Dr. Sarita Bhalerao, for bringing this prestigious CME and this entire initiative to the Mumbai Society. On behalf of my co-conveners, Dr. Amay Purandare and Dr. Komal Chavan, we'd like to express our gratitude to the Foxy President, Dr. Shanta Kumari, and the Secretary General of Foxy, Dr. Madhuri Patel as well. Since there is a family emergency, Dr. Niranjan Savan may not be able to join us physically for the event, but we have a pre-recorded talk of his, which we will play at the beginning of the CME. And for his formal introduction, I would like to hand over to Dr. Amay Purandare, my co-chairperson.
Sorry, I just need to step in for half a second.
Yes,
since Rajan is not able to join in, we will not be in a position to play his video because it's not available to the extent that we would have expected it to be. So in his place, we would be having a video from Dr. Aparna Sharma, who is one of the lead faculty and part of the entire team who has designed all of these curriculum along with WHO. And she conducted the entire master training session to kickstart this entire process. So she would actually be taking over, and her video would be played. Sorry about that. This just happened last minute, and we had
Thank
to
you, sir.
get this.
So for those of you in the audience who are unaware, Ajay Bharadwaj is the driving force behind the entire series of respectful abortion care programs which are happening throughout the length and breadth of the country. And thank you very much, sir, for stepping in and doing the honors and helping us to execute this program with Mumbai Society as well. Over to you and over to the backend team for the recorded talk.
Yeah, Amaya, I'm very sorry. Please bear with me for, please go ahead before we start the video. Go ahead and
introduction.
say a few words, yeah. Amaya, can you hear us?
Yeah, I can hear you, sir. No issues, I think.
A few words before we start the video, please.
Yeah, I think, sir, over the last decade, whenever we have interacted, I have seen your passion for safe abortion and accessible abortion for all. I think with the new amendments and the change in mindset that we are having, indeed, it doesn't seem to be a dream. I think we are moving towards its actually being a reality of safe and easily accessible and scientific abortion. So I wouldn't like to further delay the talk. I think the technical team should go ahead, and we are all looking forward to hear Dr. Aparna Sharma.
Thank you so much. We can go ahead and play the video, please.
To the MTP Amendment Act, which has been around now for a few months, and we've all heard Dr. Sumita Ghosh talking at some platform or the other, and today I'll be talking about it. But before I go on, I just want to say that we are joined here today by close to 60 master trainers who are going to be the master trainers for FOXI. So we have a fourfold purpose here. First is to inform about the Act, which has been available in some form or the other, but a formal information regarding the Act. Second is to engage everybody by talking about the methods of abortion. We all know about the methods of abortion, but yet we would like to again reinforce the recommended guidelines and methods for abortion. And the third and the most important part of this program is to talk about talking. Talk about talking to the patients, discussing, counseling. So that is an important aspect of pre-abortion and post-abortion care that we want to talk about. And the fourth part is to talk about respect. So this is the overview of this program. And we, at the end of this program, we hope to create champions of FOXI, master trainers of FOXI, who are going to take this program into their societies as the torch bearers of the respectful abortion care. So in this particular section, what are we going to look at is what is the new law, Amendment 2021, and what are the changes in rules. We will keep it very simple. If we all know why this act was required. Unsafe abortions, they lead to a large proportion of mortality and morbidity. 8% of maternal deaths per year are due to abortions, and nearly 2 out of the 3 abortions are performed which are deemed unsafe. And nearly half of the pregnancy-related deaths are in women and girls under 24. Any number of numbers that we talk about, every time we get surprised, and efforts like these are there to actually try and work towards them. So when is abortion considered safe? It is supposed to be safe when it is done by appropriate methods and by trained people. So this is something that has to be done if we want to say that we are providing safe abortion. The methods, the gestational age, the people, and the place, all of them have to be appropriate and also within the law. So this was the historic Medical Termination Amendment of 2021, which has been mandated by law, and the rules have been accepted on 25th September 2021. All of us are aware of it in some form or the other, but just to give you a proper overview of the changes that have occurred, because in some sense we need to understand what changes have occurred from previously and what is the implication of this change. So earlier, we all know that we needed the opinion of one provider of MTP up to 12 weeks and 2 providers of MTP for 12 to 20 weeks, which has been typically called the registered medical practitioner. But according to 2021 amendment, we require the opinion of one RMP for up to 20 weeks and 2 RMPs for termination between 20 to 24 weeks. And why we have done this? Because the potential outcome is to increase the number of facilities, especially in public sector like PHCs, who can actually provide services for termination of 20 weeks. So everything is directed towards increased availability of services. The next change which has come is that the modification for vulnerable age group of women, vulnerable group of women. So previously it was mentioned that MTP is permissible beyond 20 weeks only when it was necessary to save the life of the pregnant mother, and we all knew about it. But the 2021 amendment talks about special and vulnerable categories of women who can undergo termination between 20 to 24 weeks. And why did this happen? It is to increase the access for vulnerable women to safe and legal abortion defined by the Rules Committee, which includes violence victims, minors, among others. The third part and the third change is that for the birth defects and congenital anomalies, and this, as a fetal medicine person, this really comes from my heart, because with increasing detection, things have been detected, good ultrasounds, most of the cardiac anomalies being detected beyond 20 weeks. So this particular act had only termination up to 20 weeks, whatever the problem. But now the upper limit of gestation does not apply in cases of pregnancies with substantial fetal abnormalities. So anything which is diagnosed, which we know is standardly lethal, can be terminated at any gestation. And why this is important? Because it leads to increase in access to safe and legal services for those who are presenting beyond the legal limit for termination of pregnancies with substantial fetal anomalies, which are diagnosed late. With improving ultrasound, we are having these problems because we are able to detect more. But if we are able to detect and not do anything, it does not make sense. So this particular act is now aiming to provide abortion services to this particular group to reduce the unsafe abortion and court cases. All of us have handled court cases, tried to approach court for some of our patients. So this is something that is aimed to reduce all of that. Another very important aspect here is modification related to marital status. Previously, it was mentioned in the Act that the condition of failure of contraception was applicable only for married women or her husband. In view of the changing socio-cultural profile, this amendment talks about condition of failure of contraception to be extended for any woman or her partner. And why this is important? Because it provides legal and safe abortion to any woman, irrespective of her marital status. And especially with the upcoming changes in the legal age of marriage, it becomes an important advancement for increasing access to safe abortion. So a very, very important aspect is the change in the marital status of the pregnant woman. Again, the other very important issue is of privacy. So here it talks that the name and particulars of the woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. So this is another very important aspect where the privacy of the individual is considered and they are respected. So this is there to increase the demand, because we've all seen people getting stigmatized for asking for abortion. So the idea behind this is to increase the demand and the need to safeguard the rights and dignity of a woman and provide respectful, bias-free services, including counseling and contraception. And another very important aspect is, for minors, consent by guardian is simplified. So any adult who's more than 18 years of age can give a consent. It need not be the partner, it need not be the parent, it need not. So whoever is there available who's willing to take the responsibility can take the responsibility in case of for giving the consent. So if we want to talk about the salient features, the important part is it prioritizes confidentiality and safety, so that the name is revealed only if it is authorized by law. The ground of failure has been extended to the woman and her partner instead of a married woman. So when we talk about the rules under the MTP Amendment Act 2021, it defines the special and vulnerable category of women, the norms for the registered medical practitioners, and the power and the function of medical boards. Now this came on in 25th September. So the MTP Amendment Act had come in earlier on in March, but by 25th September, the rules were formalized and released in the Gazette. So when we talk about 20 to 24 weeks, it's not a blanket abortion that you can give for all women who are between 20 to 24 weeks. There are special categories who are considered to be vulnerable women. And who are those? Those who are the survivors of sexual assault, rape, incest, women with pregnancy in humanitarian settings like disaster, emergency situations as declared by government, change in the marital status during the ongoing pregnancy. Somebody has become a widow or a divorcee. During this pregnancy, they should have an option. Women with physical disabilities, major disability criteria as defined under the Disability Act, mentally ill women, including mental retardation, minors, and also the last and the broadest of category where this thing is being utilized is the fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. So all of these conditions can be offered a termination of pregnancy between 20 to 24 weeks. And this is a very, very important point to be noted and understood. The next issue is who can provide termination of pregnancy. So the norms of RMP required for performing MTP at different gestational age. Now, this particular thing is from the Primary Act itself, but what has changed is the number. So RMP is defined as MBBS or more with any of the following, which includes assisted 25 cases of MTP, of which at least 5 done independently in a hospital, who has completed 6 months of house surgency in obstetrics and gynecology, who holds a postgraduate degree or diploma in obs-gynae, and who has at least 1 year of experience of practice of obstetrics and gynecology. So this is defined as 1 RMP. Up to 20 weeks, you require only 1 RMP. Between 20 to 24 weeks, you require 2 RMPs. Now, beyond 24 weeks, it has to be a medical board. And this is absolutely essential. And most of us who have performed MTPs beyond 20 weeks or 24 weeks under the guidance of the court know that it is such a big hassle for the woman and the provider as well. So under the present situation, there are medical boards which would be composed of a gynecologist, a pediatrician, a radiologist, or a sonologist. The suggestive points would be that the head of the department of that institution must be the chair of the board. It may have at least 1 woman member, 1 member from a government hospital suggested. Specialists from any other department may be included in the board as per the requirement of the case. And any board member, if not available at that point of discussion, may be suitably substituted by another member by the chairman of the board. Now, this is something that is very, very important. These are being formed. Some are already there. Most of the state governments have started working on it. So a lot of questions are there around the medical boards that we do understand for them to fully come into action, because health is a state subject. The states have to actually make the boards. There are already 178 boards which are existing, which would be put up with support from the government of India for utilization by everybody. So what are the powers of the medical board? So medical board can allow or deny termination of pregnancy beyond 24 weeks of gestation, and it has to give a due consideration to the safety of the woman at that gestation, and also whether fetal malformation has a substantial risk. So when this act was made, it has given a lot of onus on the gynecologist and the medical boards to decide whether this pregnancy needs to be terminated, because if it was not, there would be serious or grievous physical or mental abnormalities to the baby. So this is something that the medical boards have in their power to decide. And the moment the medical boards are there, the role of the court ends. So this is a huge responsibility of the medical boards, which will be and have been defined to a greater extent within the Act. Now, if the medical board feels, for example, if there is any cardiac lesion in the baby, so the medical board can co-opt a pediatric cardiologist or somebody who can give a due opinion in that particular case. So the board may co-opt other specialists if required for deciding the termination of pregnancy. So Foxy ma'am, Dr. Shanta Kumari ma'am has also reiterated that a lot of work still needs to be done on the aspect of the medical boards. And we are seeking support from the ministry and the guidance from the ministry and WHO so that this can be operationalized at the earliest, and the information may be available on the Foxy website in some time soon. Now, the 3 functions of the medical boards would be to examine the woman and her reports, to provide opinion of medical board in the Form D. This is very important. with regard to the termination of pregnancy or rejection. So that opinion remains final, that once the board has actually seen what is happening, after that, they should give an opinion. Yes, this lady should undergo termination. They should not undergo termination. And also, they should ensure that the termination procedure, when is advised by the medical board, is carried out safely with precautions along with appropriate counseling within 5 days of the receipt of the request of the medical termination of pregnancy. This is very important because we cannot keep on dilly-dallying a procedure and the gestation keeps getting advanced. So we all understand that the second trimester abortions are risky, and hence it is also the responsibility of the medical board to ensure that it is done at a safe place. And here also, FOXI has an important role to play in ensuring that there are functional medical boards in every state, as is stated in the MTP Amendment Act. So FOXI can help in also operationalizing this procedure so that everybody is at a convenience to understand it. So this was in brief about the Act. We can have questions today, later, or on the email, or even now, and have a discussion around it. But the most important point that I want to leave you with is that India is one of the most progressive countries when it comes to the MTP Act. Abortion is now legal if it is desired or if it is actually required. But it is our responsibility as gynecologists and as service providers to make it safe and make it respectful without our own personal biases. So thank you very much. And I would like to end here.
Your closing remarks, please.
Yeah. I think Dr. Aparna has very clearly and crisply highlighted the important amendments and what the MTP Act stands as far as 2021 is concerned. I think we should utilize all this information in our daily practice, counsel properly, provide access to those in the frame seeking abortion, not be skeptical or unnecessarily worried about what or the complexities, etc. But I think that in this very simplified manner, she has made all the attendees aware. I think if the clinicians are informed, they will find it easier to implement these abortion services, ensure providing safe, successful, and scientific abortion. Over to you, Pradeep.
Thank you, Umer. I just spoke to Dr. Krishna Kumari and she's busy with the patient. She might take about 5 minutes to log in. So rather than delay the proceedings any further, perhaps we should have the next speaker.
Yeah, sure. We can do that.
Is Dr. Kiranmai ma'am there? Ma'am, would you like to step in, please?
Yeah, sure. Yes, Dr. Pratik, I'm there.
If you could share your screen, then we can get on with the task of formally introducing you.
Shall I share my presentation?
Yes, ma'am, please go ahead.
Yeah. Yeah, I hope it's visible.
Yes, ma'am. So
Yeah.
let me take great pleasure in welcoming Dr. Kiranmai all the way from Hyderabad virtually to the Mumbai OBGYN Society. We missed you at the annual conference of MOJS just last weekend when Dr. Shanta Kumari was with us. It was a wonderful event and we had the Golden Jubilee annual conference of the Mumbai Society where Dr. Shanta Kumari delivered the prestigious conference oration. And Dr. Kiranmai is well known as the right hand and the left hand of the FOXI president. She has been the silent worker behind the scenes for several years throughout the journey of the president, Dr. Shanta Kumari. And she is also well known as an ardent advocate for women's rights in general and of course for safe abortion in particular. Over to Dr. Kiranmai.
Thank you.
Pratik, just want to make one point, if I am audible.
Yes, please go ahead.
Yeah. In whatever I have interacted with Dr. Kiranmai over the last few years, every time I see an increasing amount of passion of hers to work for the upliftment of women's health. Her passion is is never, it's constant, perhaps increasing every time. So, Dr. Kiranmai, we hope to see you in the mainstream of Foxy very soon, not in the background, and all our best wishes with you in whatever endeavor you have, so that formally with Foxy, so that women are served by such passionate workers like you.
Thank you. They are really, really kind words from my colleagues and friends from Mumbai Society. Thank you so much. At the outset, let me thank the Mumbai Society President Dr. Sarita Madam and Dr. Suvarna Madam.
One second, Kiran.
Yes, ma'am. You are there? Yeah.
Yeah, I did. I just.
Please go ahead because that is the right order, I think. I'll stop sharing.
Okay.
Yeah. Welcome.
Thank you. I'm sorry. I just.
Please go ahead.
Pratik, maybe you could introduce our beloved Dr. Krishna Kumari.
Thank you very much, Dr. Krishna Kumari, for joining in, and we present apologies on her behalf for having logged in a little late. To formally introduce Dr. Krishna Kumari, Madam is a gold medalist at MD and DGO. She's a professor at the Apollo Hospitals in Hyderabad, senior consultant at Medicover Women and Child Hospitals in Hyderabad, national corresponding editor of Jogi, national coordinator for Foxy 2021-22, member of the Research and Good Clinical Practices Committee of SAFOC, Vice President of TCOG, Governing Council member of ICOG, and she served as a President, Secretary and Treasurer of the OBGYN Society of Hyderabad in the past. Over to you, ma'am.
Thank you very much, Dr. Pratik, for that kind introduction. At the outset, my sincere apologies for being a few minutes late. Ajay, don't look at me angrily. I couldn't help it. I had to rush through the traffic to reach in time. And people from Mumbai will definitely understand how difficult it would be. So I just had to rush in. And when Pratik called me, I was opening the door. So I just told him, give me 2 minutes, I'll join you.
No, it's an absolute honor. It's an absolute honor and pleasure to have you here.
Thank you so much. I think I'll go ahead with my presentation. Can I have the share screen? Yeah.
Sriman, could you just check it's all frozen now?
Yes, sir.
Ma'am, you are muted. Unmute yourself. Yet to see. Yes.
So is my screen visible?
Yeah, go to the slideshow now. Yes. Visible.
Okay. Am I visible? Am I audible?
Yes, madam.
Yeah, sure. Thank you.
Yes, ma'am. Both visible and audible. If you could just share your screen, please.
Yeah.
And put it in slideshow mode.
Right. 1 second. Just give me 1 second. I'll give. Right. Sorry again for the one after the other glitches, I think.
Yes, ma'am.
Thank you all.
Fine. Please go ahead.
Yeah. So today, this session is about the updates in technology. And most of the updates are already, all this technology is mostly known to most of us. And there are a few changes which have been brought about in the technology, which we are going to go through in the next few minutes. And we're going to talk about the already existing guidelines, the pre-abortion assessment, the medical methods, and the surgical methods of abortion. So as we all know, the WHO global guidelines on safe abortion have been there with us for quite some time. These are all global guidelines. And for people who want to go into the detail of each aspect of it, can go through any of these volumes which are available both on the internet as well as in hard copy. So these are all available, and you can just go through if you are specifically interested in any specific issues. So it's not only the global guidelines, it's also they have tried to indigenize, and they have also brought in the WHO in collaboration with our government of India has brought in other guidelines which are more adaptable, which have been adapted to our own people. And starting from 2012 to 2019, we have different aspects of it, whether it's a technical and policy guidance for health systems, or whether it is a handbook on safe abortions, or the role of the health workers and the abortion guidelines, as well as consolidated guidelines on self-care intervention for health. So all these things have been brought into different booklets, and these are available also for our own perusal whenever and if ever we are interested. And as far as the newer guidelines are concerned, we all know that it has been quite some time since the discussions on the different changes that have to be brought about in the law. The various discussions with all the stakeholders has been going on for quite some time, and it was finally changed in the month of March 2021, but after which it was gazetted, and then it has come into play from 24th September 2021. So the guidelines have three key areas in management. That is, one is the pre-abortion care, one is the abortion care methods, and the third is the aftercare and follow-up. So it's all about the decision making, and it also includes everything which has to be done from the time the patient comes to us, a proper history, to discussing about the contraception. All of them have been brought into these guidelines. So pre-abortion assessment and counseling, basically it starts with a detailed history taking, followed by a general physical and a pelvic examination, and followed by lab and other investigations, and decision-making information on the different procedures, methodology of doing the abortion, as well as the counseling, including contraception. All these have been taken into account. As far as calculation of the gestational age is concerned, I think we all of us as obstetricians and gynecologists are thorough regarding the calculation of the correct gestational age, how to go about it, whether it is from the LMP or whether it is, if the LMP is not known, if the height of the uterus is bigger than what it should be, it's not corresponding to the gestational age, how to go about it. Either if it is more than the gestational age or less than the gestational age, the differential diagnosis. I think to such an august audience, I don't need to explain to them regarding this particular slide, where the correct gestational age has to be evaluated clinically as per the history, and then the physical examination. So the most important change that has been brought about is in the pre-abortion investigations, routine lab tests are now not a prerequisite for abortion services. This is what, when they say a word not, it does not mean you should not, but it means it is not mandatory. So we just have to remember that all these guidelines, after having repeatedly interacted with people regarding this aspect of the guidelines, I have realized that there are certain things which keeps there is always a query that is springing up, whether we should do or we shouldn't do. We should remember that India is a country of diversity with both the public and private health sectors. And not only it is having public and private sectors, whether it's in the private sector and the public sector, again, we have a huge range of the amenities available. We have very small hospitals or PHCs or very small nursing, or what we call as clinics or nursing homes, to very well-developed corporate setups or well-developed tertiary care centers, even in the government, under the government programs. So this is meant for, these guidelines are meant to make the women be able to reach at every crook and corner of the country an individual who is able to do a abortion technique for them with due respect. That is the whole purpose of these guidelines. And so it has been said that routine lab tests are not a prerequisite for abortion services. So what are the tests that need to be done? If you're not sure if the test is not performed before, you can confirm the pregnancy. Then you do a hemoglobin or hematocrit if you're suspecting anemia. And if you have a Rh immunoglobulin available and she's an Rh negative woman, it is very, we need to know the status of the Rh status. Then HIV testing and counseling if you think it's essential as per your history, and STI screening. The importance of pelvic examination is something which is we have been stressing upon time and again, and it is very important that in your clinical examination where you can exclude to a certain extent the presence of STI in STIs too. Then other lab investigations which are to be done are based upon any additional medical history you have elicited, whether the woman has any prior kidney or liver problems or so. And again, the statement that is being made is that ultrasound is not necessary unless we are wanting to diagnose pregnancy which is not a healthy one, that is either an ectopic pregnancy, a miscarriage, or any other reason. If you have a specific reason for which you want to think that ultrasound is mandatory, yes, you can go ahead and do it. But it is not necessary to do it just to do an abortion. So the pre-abortion counseling, you should what you should ask the woman is her thoughts about terminating the pregnancy, and if she has any reason for terminating, and inform her that early abortion is safe. Then the need for a trained provider to do it for her own safety in a place which is being approved, and what are the different methods of abortion available at her gestational age, the risks and warning signs associated with the particular method that she has chosen. And if she has not been into contraception, we have to enlighten her that within 14 days of aborting, she is likely to ovulate and again get pregnant. And then resumption of a normal activities, including sexual intercourse and any other follow-up care that is required. And what we need to document is a informed written consent, as well as her decision of if she has accepted any post-abortion contraceptive. Then you have to put it on paper and document it. But suppose she is not agreeing for any contraception, still you have to remember that you have to go ahead and give her the abortion services. So that is what we have to do in the pre-abortion period. Then coming to the how do we do the technique. So as far as the methods are concerned, globally it has been accepted that less than 12 weeks, the WHO recommends either the usage of mifepristone in combination with misoprostol or misoprostol alone, or vacuum aspiration. Whereas after 12 weeks, it recommends either mifepristone and misoprostol or DNE. Of course, DNC, especially sharp curettage, is not advised in any pregnant women. But as far as our country is concerned, the GOI recommendation goes that only up to 9 weeks we are given this advice to do this particular method of, especially the medical termination, is allowed only up to 9 weeks. And they have a different protocol up to 7 weeks and between 7 to 9 weeks. So up to 7 weeks, you give first mifepristol 200 milligrams oral dose, wait for 24 to 48 hours, and followed by misoprostol 400. It is not 800, it is 400 micrograms, either sublingually or by buccal. Whereas if it is beyond 49 days, that is between 7 to 9 weeks, mifepristone is followed 24 to 48 hours later by misoprostol 800 micrograms sublingually or by buccal way. But you have to remember that it is mifepristone 200 milligrams remains constant. What is changing is after 36 to 48 hours, the usage of misoprostol. The dose is 400 micrograms up to 7 weeks and 800 micrograms after between 7 to 9 weeks. So we all know about first trimester. Remember the today's guidelines include only regarding first trimester abortion. And in the first trimester abortion, it could be medical or surgical methods of evacuation. So when the mifepristol, all of us know, is an antiprogestin which inhibits action of progesterone, interferes with continuation of pregnancy, and initially it is given. After that, it is followed by misoprostol, which is a prostaglandin E1 analog, and this causes cervical softening, uterine contractions, and expulsion of products of conception. The advantages of the way it is given is the mifepristone on day 1, it is administered 200 milligrams along with anti-D if the patient is Rh negative. And day 3, you give mifepristone 400 micrograms, 7 weeks, at any of the routes, that is sublingual, buccal, vaginal, oral. And between 7 to 9 weeks, you give 800 micrograms. In addition, you also give analgesics, antiemetics, and again offer contraception. And within 15 days, you call up for follow-up. Yeah.
Sorry, I'm not able to see the slides. Is it everybody else is able to see? I'm not able to.
Really?
Your screen share is gone off, ma'am.
Yes. Need to share again. Maybe 1 or 2 slides, I think.
Now?
Yes, yes.
Yes, ma'am. If you could just go full screen, please.
Full screen.
Yeah, I'll go. Which slide did you miss?
The one before this.
Yes.
This one?
Yeah, from this point onwards.
Yeah, this one. Okay, this one is at 7 weeks one and the 7 to 9 weeks one, which I was telling about. Anyway, we are going to come to that again. Can you see this now? Hello?
Yes, ma'am. It's visible.
Okay. Yeah. So we have the medical and the surgical methods, and the role of how MIFI and MISO act. Those are the 2 ways by which they act. And then, like I said, mifepristone on day 1. This was a slide I was talking about. Mifepristone on day 1, 200 orally with anti-D if a patient is Rh negative. And day 3, mifepristone up to 7 weeks, 400 micrograms, either sublingually, buccal, vaginal, or oral. Between 7 to 9 weeks, it is 800 micrograms, sublingual, buccal, vaginal. And in addition, you give analgesics, antiemetics, and contraception as and when needed. And within 15 days, we call them up to confirm and ensure completion of the procedure, and again offer contraception if we have not done so already. So basically, we all know the advantages of all the different routes. We have to understand that the fastest route is a sublingual one, but the oral, buccal, and sublingual ones are associated with more side effects like fever, chills, diarrhea, vomiting. And the lowest rate of side effects are seen with the vaginal route, where they are placed deep in the vaginal fornices and the woman is instructed to lie down for 30 minutes. That is the having the least side effects. Buccal, this is a buccal, and the other one is a sublingual under the tongue. Buccal is between the cheeks and the gums. So the dosage regimen goes like this. In induced abortion, less than 12 weeks, 200, followed by 2 days later 800. This is for the global recommendation. And alternatively, the route has changed. They have given, in Western countries, only misoprostol also is given, but we in our country do not use misoprostol alone. They have given it as an alternative when without mifepristone, only the usage of misoprostol, 800 micrograms by any of the routes. And we have to also educate the patient that vaginal bleeding is common for 2 weeks after medical abortion. And rarely this bleeding can even last for up to 45 days. And you should be seeing that the services are available at the primary care level with adequate referral systems where to a higher center in case if there is any requirement. Additional services at the same time, you should take the advantage of giving a holistic treatment to the woman by looking at, by counseling her, testing for STI, abuse support services, psychological or social services, or other specialist health and medical services as and when necessary. Give her iron tablets for anemia and any pain medications and provide her with emotional support if needed. Again, follow-up care is not mandatory as per this by the newer guidelines. We need not ask her to come back unless if you are giving only a misoprostol protocol. If only misoprostol is given without MIFI, then it is mandatory that she comes back to us for a follow-up, usually within 7 to 14 days. And this is an opportunity where you look at her emotional support, address any medical concerns, and most importantly, once again, stress about contraceptive counseling. The follow-up care of the women is you should assess her recovery and ask for any signs or symptoms of ongoing pregnancy, review any medical records and referral documents, ask about any symptoms experienced, perform a focused physical examination, and assess her fertility goals and need for contraception. So on the first day, you do a physical and pelvic examination, confirm eligibility, give her TAP MIFI, offer anti-D if she's RH negative, ask her to come back for meso after 2 days, give her a contact address and phone number and center, record her experience. And you, although 3% of the women spontaneously expel completely after giving only MIFI, you should complete the course of misoprostol too. And second visit on day 3, you give misoprostol, then observe her for 4 hours. In case of pain, you can give her ibuprofen and give her contraceptive options and tell her the period of bleeding, the side effects, how to report, where to report. And within 4 to 6 hours, 75% of them abort. On the third visit, they do a pelvic examination, discuss about the contraception, and again about her possibility of a return to fertility and report back if there are no periods within 6 weeks of the process. Ultrasound is advised if you are clinically not satisfied by your examination that the procedure has been completed. So for the side effects, pain, you can either give her ibuprofen, counsel her, talk to her, and then be non-judgmental. And if there is persistent pain, you have to exclude other reasons like ectopic infection or incomplete abortion. You have to tell her nausea, vomiting, diarrhea, infection, diarrhea are self-limiting. Infection has to be confirmed by physical examination and then go ahead and give antibiotics. In case there is a failure, you either offer them vacuum aspiration or repeat your misoprostol dosage. So if the bleeding is minimal, you ask them to again wait for some more time and observe her and see if she will abort. If the bleeding is heavy, or if she wants, you can offer her either a repeat misoprostol or offer her surgical method of evacuation. This is exactly observation and monitoring her vitals and then taking a call based on that. So you have to report it. It is mandatory. You have to fill all these forms. Form C is the consent form. Form 1 is the RMP opinion. Form 2 is the monthly reporting form, which we send to the district heads. Form 3 is the admission register for the case records. So other than the medical, we also have the surgical methods. That's the vacuum aspiration. And vacuum aspiration is recommended to be the safest. And you should never do a sharp curettage. Vacuum aspiration has both manual and electric ones. The manual vacuum aspiration, we all know they have been different. They have been all been trained in this, how the cannula are available, the iPass cannula and easy grip cannula, the size which corresponds, and you create a negative pressure and then suck the products. Electric vacuum aspiration is when you accommodate you use an electrical machine to create a negative pressure. If necessary, you can also do a cervical priming by oral mifepristone 200 milligrams, misoprostol 400 micrograms sublingually 2 to 3 hours prior, or vaginally, or rarely. Nowadays we are not using. Previously we used to use laminaria intracervically. So pain management is very important, non-pharmacological and pharmacological. And the pharmacological procedure depends upon what the patient feels. If she's anxious, give her anxiolytics or GA. If the cervical dilatation is painful, give her paracervical block with xylocaine or an NSAID. 1 hour prior to the procedure, it remains for 4 to 6 hours. If there's a cramping type of pain, you can give her again ibuprofen 400 to 800 milligrams, and the effect will be there for the next 4 to 6 hours. But remember, she can have gastritis. The steps of MVA, I think all of us have been trained in this, how to go fix the cannula and how to create the negative pressure and how to suck the products of products. And then you have to inspect the tissues, and then concurrently, if you want, you can do sterilization or IUCD insertion. And then you also have to see that the instruments are properly cleaned in chlorine solution, which removes the tissue and body fluids. Post-operatively, you have to monitor her for any complications and provide management, and she may leave the facility whenever she is stable. You give her the needed necessary and medication and document all the outcomes of the treatment. And any abortion complications you have to manage, provision of contraceptive information, contraceptive counseling methods, and any other sexual and reproductive health needs should be addressed. And like I already told, unless MISO alone is given, there is no need for routine follow-up. So India has made historic progress in improving access to safe abortion. We should be proud that it has made respectful abortion care is made available to all the women. Not much has changed in technological update, and it is up to us to ensure safety and quality, especially in context of amended law. Along with safety, we also need to focus on the respectful abortion services. Every client should be informed, educated, and equipped with proper information on contraception and counseling. Please do your pre and post test and give your feedback. And then, of course, in India, we are proud that abortion is made legal. Thank you all. And once again, I apologize for the glitches that happened in the process. Thank you.
Thank you, Dr. Krishna Kumari, for taking us through the entire medical part of abortion. I think your entire presentation was a very good comprehensive coverage of the medical aspects, especially in the light of the recently amended MTP Act. Amay, your closing remarks, please.
Yeah, I think Dr. Krishna Kumari very correctly said during her presentation that the medical methods of abortion are being more and more accepted and offered by clinicians to their clients. I think that it is a safe type of abortion. It is a simplified method of abortion. And I think now with the new MTP Act, it has come into the purview of the MTP Act, and therefore we must utilize it wherever necessary. At the same time, proper counseling to ensure complete abortion or to detect any complication with this method should be carried out, and a proper record of the same should be kept. So thank you, Dr. Krishna Kumari. It was a very, very lucid and very, very practical talk. And I think it is going to benefit the attendees immensely. As always, you have kept it scientific, and I have seen that over the last so many years that you have always been someone who has not compromised on any form of evidence in medicine. And I'm sure that in your journey in ICOG, you will continue the same. Thank you.
Thank you. Thank you so much, Shamaya. Thank you. It was a pleasure being with all of you. Thank you, Dr. Pratik and Dr. Maya. Thank you.
Thank you for being with us, ma'am. And before we sign off, I'd like to express my gratitude to our MOGS President, Dr. Sarita Bhalera, Secretary Dr. Suvarna Khadilkar for having Amey and me both here as chairpersons and as co-conveners for this program.
Pratik, Dr. Kiranmai would be speaking, or
I can
we'll
go.
have the next chairperson to be introduced,
yeah,
and then we'll have Dr. Kiranmai starting to speak.
yeah.
Over to Riddhi.
Thank you so much, chairpersons and our speakers, for giving us such an informative session. And now I would like to welcome our next chairperson, Dr. Preeti Vyas. Madam is a consultant at Sangeeta Maternity and Surgical Diagnostic Center and Hinduja Healthcare, Mumbai. She is MSc in Psychological Counseling and Therapy. She runs one-to-one guidance centers for adolescent pre-marriage couples, women with intimacy issues, and she is the MOGS Managing Committee member and MOGS Youth Cell Mentor. We welcome you, ma'am. Dr. Komal Chavan, our next chairperson, ma'am had a family emergency and could not join with us. So over to Dr. Preeti.
Thank you, Riddhi, so much for a kind introduction. I'm blessed to be here today on such a fantastic program, which is something which is so important. And I think this new law, everything, I think it's very important that we do more and more of these programs, because not too many people are as yet aware of the new amendments of the laws of MTP and the abortion care. So now the speaker we have with us is Dr. Kiranmai. Dr. Kiranmai Devinani is a professor at the Government Medical College at Telangana. He is also the coordinator for the initiative, the vice president and secretary OBGYN Society of Hyderabad in the year.
Yeah, Dr. Preeti, I think I'll go ahead because, yeah, thank you so much, Chairperson. Dr. Bharti has to be muted. Yeah. My slides are visible full screen.
Yes, we can see it.
Yeah, thank you, ma'am. So, as Dr. Aparna in her first lecture very emphatically told about the 4 components of RAC, and one of it is respect. And our module, our program today itself starts with the respectful abortion care. So you can understand how important that component of the abortion care is for us. So this module is regarding the safe abortion values, evidence, rights and respect, which is called popularly as SAVOR module of WHO. And as you all know, that this is joint FOXI and WHO initiative under the leadership of our president, FOXI, Dr. Shanta Kumari, and the entire team FOXI. So we'll talk about what constitutes respect and what are the factors which affect this respectful care that we are going to give to our patients. So the module aims to define what exactly is respectful abortion care as per WHO standards, highlight mainly how our norms and stigma without knowing affect this respect component of the services, and also provide some of the resources for this SAVOR module of WHO for RAC. So we know that now the momentum has been created, the law has changed, and now it is the dissemination which needs association and OB-GYN provider support. FOXI, we all know, is the largest provider base for the abortion care, and who else other than FOXI to do this immensely important job of disseminating this module of respectful abortion care across the country to all our colleagues. And now, because online training is possible due to as a offshoot effect of COVID, so we are able to reach all the providers. And as Dr. Krishna Kumari Madam has told, MMA uptake has increased, increasing the early and safe abortions, and to ensure no PCP-NDT conflation. So now patient safety, respect and quality matters more than ever, and we all have a role to play and kind of unlearn or relearn certain aspects. So by definition, adopted from WHO, respectful abortion care is a care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. So you can see this entire module stresses upon these points repeatedly. So in simpler terms, it means that you as a provider or as a patient, if you are a provider, you treat, and if as a patient, you are treated with dignity, empathy, and compassion, irrespective of your identity, your race, your ethnicity, your gender, your socioeconomic status, or reproductive history. We as obstetricians and gynecologists generally do not discriminate on the basis of any other thing, but reproductive history does get to us, most of us. The number of pregnancies, the number of miscarriages, how late she has come in her abortion, whether she's married or not, how many children that she's having, all these things. So these discrimination creeps in, especially when we hear the reproductive history. So if you ever feel that something isn't right, if you are a patient, you have to speak up. And as health professional, it is our duty to listen and support. Again, the communication and counseling is the key. So what are norms and stigma? So this is an interesting video from, Shriman. Let me stop share. Sorry. Is the volume coming?
Yes, ma'am.
Anyway, to share sound, I didn't. Okay. Sorry.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID 19, there are new social norms that are considered COVID 19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others personally and professionally.
So the stigma and norms, why we have had this detailed video is that these can be the foreground on which the disrespect and abuse flourish. So when we have stigma, definitely we are going to label or judge the patient and maybe kind of abuse her, or comment on her, or that would lead to disrespectful behavior, and then later abuse. So it is very, very important to keep the stigma and norms separate from the law. So you may have your own personal beliefs and understanding or social conditioning, but it is very important to unlearn that, and if not possible, at least keep that away from the law and the care that we are giving to our patients. So what are the category of disrespect and abuses? It may be very surprising to say that there could be physical abuse or slapping or intimidating physically, but when you interview patients or so the people who have taken service, definitely they do come openly about having faced physical abuse, at least from the if not from the doctors or from the class 4 or other people, though it doesn't occur now, it did happen and used to happen in the past. So this physical abuse is one very important aspect of disrespect. And then verbal abuse is non-consented care and shouting and screaming at the patients. And then sexual abuse, abuse of power and taking advantage of the vulnerability of the patient. And then as we have seen this stigma and discrimination, the belief systems that we have, how they lead to discrimination of the patient depending on her married status or number of pregnancies or number of abortions, etc. Then finally, the failure to meet professional standards of care and the poor rapport between women and providers, and the health system conditions and constraints like overcrowding, the public facilities, and the lack of infrastructure, etc., can predispose to disrespect. And then as opposed to this disrespect and abuse, the rights of the women. It's the right of every woman to have freedom from harm and ill treatment, and the right to information protection under laws like MTP, POXO, informed consent and refusal, and respect for choices and preferences, dignity and quality of care, and right to timely health care and to the highest attainable level of health. And then liberty, autonomy, self-determination, and freedom from coercion. We do know all of this, but it is our responsibility to ensure that all these rights reach our women. Then what are the domains of respectful abortion care? There are 12 domains. Let me just recount all of them because they're all very important. Being free from harm and mistreatment, maintaining the privacy and confidentiality, which is very, very important. And again, it will be stressed upon how we cannot divulge the details of the patients in MTP, and preserving women's dignity and respecting her choices, whatever they are, and engaging with effective communication, the role of soft skills. I think Dr. Lakshmi Madam next will definitely elaborate on this, and providing information and seeking informed consent, ensuring continuous access to support pre, post, and also during abortion, then enhancing quality of physical environment and resources, providing equitable abortion care. What is equitable? It is a fair and unbiased, giving the fair share and unbiased judicious care, which is called equitable. And then availability of competent and motivated providers who are motivated to provide this respectful abortion. Then provision of contraception advice and commodity security, which is very important to club the contraception along with abortion services and continuity of care and counseling at all stages. Then now it is the time to strengthen the implementation. We know the changes in the law, actually it becomes even more, the onus is even more on us, because up to 20 weeks it is only one provider, and every patient is an opportunity for respect, and as providers the onus is on us to educate and also reduce sex selective abortion up to 20 weeks. So the more responsibility regarding counseling, contraception, referral and compassionate care. And then coming to 20 to 24 weeks is the new section, which includes the vulnerable group, which needs more compassion, less judgment. Especially we might have young people, unmarried minors, then survivors of rape, and then widows who are more prone for judgment and lack of provision of abortion care. This is the section where we need a lot of more sensitivity and judgment free and timely services. And again, to stress upon, we need to be mindful of socio-cultural aspects and give respect begets respect and prioritize the confidentiality. So this video is a little long. I'll just go through it quickly and just highlight what are the important points. So we do use a lot of words and language in while talking about abortion care, either among colleagues or to the patients. There are a lot of words which we use unknowingly, but which should not be used. Let's just go through them. So abort a child is not right, because the fetus is not yet a child, and terminate a pregnancy is a better word. And it is important to be legally accurate, because many times even if it is legal, we may shy away from providing abortion care because of conflation with other laws like POXO and PCPNDT. So we have to be very sure what is legal, and if it is within legal purview, we have to provide the abortion care. And then avoid stigmatizing words like abortion provider. The better word is healthcare provider or RMP. Then avoid using terms like fetus and child. Products of conception is a better word. And then you can't refuse on moral grounds. You cannot say to the patient, I don't like morally to do abortion, because the refusal should be based on legal grounds. For example, a sex selective abortion, not on your own moral issues. Then always remember, abortion is without compromise, without any ifs and buts. It's a woman's right and choice. And always there are a lot of terms we loosely throw around, like unintended pregnancy, unplanned pregnancy, unwanted pregnancy, mistimed pregnancy. Each word is different and it has to be used appropriately. And always avoid the use of words ending with side, like feticide. Even we do in our, though we know that we should not use, we keep using the term like female feticide, which should not be used. The better word is sex selective abortion. And always, sometimes we may use terms like get rid of this pregnancy. That should not be used, because it is disrespectful. And also equally disrespectful is to counsel that you can keep this child. So it's not a child, and you cannot be judgmental about it. Choosing the terms like you may choose to continue with this pregnancy, or you may choose to abort this pregnancy. That is a better word. And then coming to the new amendment, we have late abortions now. So don't use terms like late term abortions. Abortion in second trimester or third trimester, depending on the fetal anomalies, might be a better word. And then abortion at so many weeks might be a right word. And again, avoid using terms like mother, father, parent, which kind of puts the onus and on the partners who are yet to become parents for this child. So always better to use a pregnant woman, not mother, father or parent. Always remember, fetus is not a child, and you cannot go on talking about preventing abortions, reducing abortions. Yes, that might be the intention, but reducing the access to abortion, always remember that it is not going to reduce the unsafe abortions. And you might stress upon increasing the use of contraception, but don't use these words. And again, repeat abortions also has to be avoided. You can say more than one abortion. And again, be familiar with the correct use of words like pro-life, pro-choice. It is not anti-life or anti-choice. And then illegal and safety, both are little different. It might be illegal because if you are not doing it according to the law, you might be doing illegal, but it could be safe. So it could be, abortion could be illegal but safe. It could be legal but unsafe. So what are these safety points is safe abortion, legal is regarding the 3 P's, safe abortion. It is 3 P's are person, place and process. And it has to be done in safe conditions by trained and certified persons. These are the characteristics of safe abortion. So again, unwanted is undesirable, whereas unplanned can be either wanted or unwanted. So this is the highlights of this video. Because it is too long, I would skip this. So this is another small video. I would request all of you to pay attention, because this is the Saver Toolkit resource in the WHO. We'll just go through this video quickly.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Saver, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Saver Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Saver is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So these are the games which are available, and these are the links which are there. I did try the 1 or 2 games in this. In the Cross the Line, the first question was whether women are emotional. What do you think? We all know that we know that women are not emotional, but it was supported by evidence which clearly said that women, there is nothing to say that in the brains of the women that they are more emotional. And then in a personal compass also there was a question which you take whether you agree or disagree, and then it is discussed beautifully with evidence. And you can try this Saver module, go and have a look at it, and also can try these games. So from 1970 unsafe abortion to 2000 safe abortion, and now we have moved to respectful abortion. So just put down 2 recap questions. Please type in chat box so that we can have a quick understanding of how much of what this module has reached to us. So the first question is, according to the WHO, restricting access reduces the number of unsafe abortions. Is it true or false? I would like to have some answers in the chat box, because this question and this opinion led to lot of heat in one of our groups, and it need not be you can put in your opinions, definitely. Yeah, I did. Yeah. So false, false, false. Most of them are false. I'm very happy about that. So it is indeed false, because by restricting access, we are not going to reduce the number of unsafe abortions. So what are the criteria of safe abortions? As I have told, it is P, P and P, that is by appropriate methods, by trained persons. That is the only criteria we have to see, and by actually restricting access, the number of unsafe abortions goes up and not the total number of abortions. Again, this question always generated a lot of divided answers, but it is very important to know this. The MTP Amendment Act 2021, please read the question carefully, requires a minor of less than 18 years to obtain written consent from parents and guardians before she can undergo a termination of pregnancy. Do you think it is true or false? False. Few more answers before we go to the correct answer. False, yeah. There is one true, is it? Yeah, Dr. Shweta feels true, but most of it is false. Yeah, there is some little, nuance in that. So actually it is false. Yeah. So I know the answer why it is reported as true is, one is because she's a minor, the other is the POXO. So now the written consent is not required especially from the parents or the legal guardians. A minor can be accompanied by an adult guardian. That's it, and that is it. Who can sign the consent as an accompanying person. So a parent or a legal guardian, it's not mandatory now. That is one important change, because minor under 18 years comes under the vulnerable group, and this is one section where we have to be very kind of careful in providing and not refusing the care. And POXO reporting, as far as it is concerned, it is still needed because she's a minor, but abortion services should not be denied, and we need to provide bias-free services without judgment for this group. And another question again, a 30-year-old woman recently widowed wants to get an abortion at 22 weeks. Here, one is she's a vulnerable group, belongs because she's recently widowed, and gestational age is 22 weeks. So now this comes under the new amendment. As a provider, it is your responsibility to tell her to continue this pregnancy. Is it yes or no? No. No. Okay, wonderful. So it is not our yeah, it is no, definitely, because again this is where the law has become more liberal and more respectful. Even when in this module, this particular section of the group, I mean vulnerable group, where they have asked us to be very mindful of disrespect or judgment in this group. So it is not in our place to tell to continue this pregnancy for this woman. So only we have to remember, because it is false above 20 weeks, we require 2 RMPs, that is it. And that is the requirement that we have to, and also give respectful abortion care. So again, this last slide is really all our, all of us favorite ending point. I think we are very proud that in India, abortion is liberal and one of the most progressive acts, even when compared to one of the most developed countries in the world. And abortion is legal. It's up to us to make it safe and respectful. Safe abortion made available respectfully throughout health systems, that is Samarth Bharat and Sampurna Bharat. Thank you so much for a patient hearing.
Thank you so much, ma'am. I think it was a wonderful presentation, and your slides were so apt. I loved some of the slides where it was so clearly written, where up to 20 weeks, between 20 to 24 weeks, beyond 24 weeks. And I think that is a kind of a message that we all must probably put up in our clinics, because it will help as a this thing, and maybe it should be put up in all the BMCs and all in the teaching hospitals also, because it is such a clear-cut message given. Not only would it help to spread the awareness about it, but even women will feel empowered when they know that they don't need to be scared anymore. And I agree, I think ours is a very liberal society as compared to a lot of Western countries, where as yet, even in this day and age, a lot of states have abortions which are illegal, and they are in fact not allowed at all. So thank you again, madam.
Thank you, Dr. Preeti ma'am. Actually, this module was prepared by wonderful team from Government of India, AIMS, WHO, and they have done a wonderful job of it. Thank you so much. And there is one query from Abhinaya that whether we have to report all the minors to POCSO. Yes, we have to. That is mandatory. With this, I hand over back to Dr. Riddhi and Dr. Preeti ma'am. Yeah.
Yeah, I think so. Before we go to the next speaker, Dr. Lakshmi, I'd like to again thank our conveners for today, Dr. Pratik, Dr. Amaya, and Dr. Komal, for giving us the opportunity. And of course, the president of MOGS and FOXY both, along with the secretaries, Dr. Suvarna and Dr. Madhuri, for thinking about such a nice comprehensive module and taking this forward to spread awareness in the country. Now, next we have Dr. Lakshmi. Dr. Lakshmi Shikhande is the chairperson-elect of ICOG. She's a national corresponding editor also of Jogi, the founder patron as well as the president of ISOPA Vidab chapter, chairperson of the IMS Education Committee right now, and has received N number of awards, one of them being Nagpur Ratan Award, the Bharat Excellence Award, the Merudar Hatsotia Award. She's even received an appreciation letter from the Maharashtra government for her work done in the field of Save the Girl Child. Madam has been a senior vice president in the past of FOXY, and right now is the medical director of the Shikhande Fertility Clinic, Nagpur. She's going to talk to us about the pre and the post abortion family planning counseling. So over to you, Dr. Lakshmi.
Thank you. Thank you so much, Preeti. Now, after listening to the MTP Act, the amendments in MTP Act, the technology update, and the safe abortion values, now this is the talk on pre and post family planning counseling. Because we all know counseling plays a very, very vital part of the family planning services. So what do we mean by counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment.
Dr. Lakshmi ma'am, sorry to interrupt.
Lakshmi madam, could you go full screen, please?
Full screen.
I am full screen. It is not showing full screen.
You've shared the wrong screen then. Please stop sharing and share again.
Okay. Just a minute. Now is it full screen?
Not yet, ma'am.
I think that
Madam, click on the slideshow, madam.
I did it. My net is unstable. Now?
No, madam. Still, you can see the slides only.
Yeah, just a minute.
I think you'll have to just double click on the first slide and see.
I did, Preeti.
नीचे से भी नहीं हो रहा है क्या वो? In the last नीचे का जो ये है ना, हाँ
होगा तो बता, मैं हॉटस्पॉट से भी ले रही हूँ अभी. हाँ.
Actually, this thing is in the tile format. So in the lower end corner, usually the lower end, नीचे से lower end corner में, हाँ उधर से you'll have to, yeah, just see.
अभी हुआ?
नहीं, not yet.
नहीं, फिर नेट का प्रॉब्लम है, because I am sharing this for the first time. तो फिर श्रीमन वहां से करोगे शेयर, कैसा करोगे? हाँ, श्रीमन के पास है, फिर उसको शेयर करना पड़ेगा। मैं स्टॉप करूं श्रीमन?
Yes, sir.
I have stopped screen sharing.
Is the screen visible, ma'am?
Yeah. Now you all can see.
Yes, ma'am. Please.
Shriman,
Yes, yes.
Shriman, go next. Next. Here there is a video. Shriman, go back. Is there a video on this slide? Back. Yeah. Is there a video?
No, ma'am.
No. Okay. So yeah, please next. No, go back. I was talking on what do we mean by counseling. Counseling, remember, it is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. And you all will agree with me that each and every word here is very, very important when we counsel our patients. Next. So what are the components of pre and post abortion counseling? We all know it is an integral part. It is as important as the procedure. Some women, they may need help in decision making. We know there are some women who come to us with their decision, and whenever needed, at least in India, we should try to counsel the spouse as well. Next. So first and foremost, we have to help women decide about termination of pregnancy. And that is what I was saying. Many women, they come to us with a full determination that they don't want to continue this pregnancy. They want to go ahead with termination. But there are some women who are in doubt. And here comes our role in helping them to decide about termination of pregnancy. Once she decides that she wants to go ahead with termination of pregnancy, then we have to help the woman to choose the method of termination. Once she agrees to the method of termination, we have to ensure complete delivery of the information about the procedure. You have to tell her in great detail about the pros, cons, about the complications, everything about the method which you both have chosen for that particular woman. And then you have to counsel the woman to decide about a contraceptive method after she undergoes termination of pregnancy. Next. Whenever you are doing counseling, it cannot be done in an open area. You have to ensure the privacy and confidentiality. And as Dr. Kiranmai has emphasized in her talk, that we all service providers have to be non-judgmental and we have to be very sensitive towards this aspect. We should establish the rapport with the woman. We should use simple language and allow the woman to clarify her doubts. If she has made up her mind for termination of pregnancy, then comes the next step, that is you have to start assessing her for the procedure. Next. And what is the relevance of this peri-abortion family planning counseling? You have to tell her that there is a quick return of fertility once the abortion procedure is complete. This is the right opportunity for us, for we service providers, to counsel her for contraception, as the contraceptive acceptance is higher at this period of time, and we have to counsel her that she should give minimum 6 month gap before she conceives again. And we have to also tell her about the health benefits and future pregnancy outcome if she agrees to use a contraceptive method for at least 6 months before she becomes pregnant again. So 90% of the abortion-related maternal mortality can be prevented by ensuring contraception, because we all know that majority of cases of termination, they are unintended pregnancies. And if we can make contraception easily acceptable to these women, then we can reduce the chances of unintended pregnancy and thereby the mortality and morbidity related with the termination of pregnancy of these unintended pregnancies. Next. So when you should start counseling this woman? You can start your counseling during the first visit itself when she has come to you for consultation. There is an exception that if there is a loss of the child, or if this is a missed abortion, they are in grief, then you have to delay this counseling. What to counsel, that is also very, very important. So in simple language, you have to tell her that she can become pregnant again, even after 10 days of termination of pregnancy. You have to help her to decide about the choices of contraception. Once she decides the method, then you have to do the method specific counseling, and you also have to counsel her about high risk behavior wherever this is applicable. If the woman is not willing for any contraceptive method, do not refuse MTP. Try and counsel her again after the procedure is over. If she is still not willing, then call her for follow-up in a week's time and counsel her again for contraception. Next. So you have to assess the suitability for post-abortion contraception. You have to be very sure that the abortion process is complete. There is no existing pelvic infection. There is no injury to the genital organs, and the chances of fresh pregnancy has been ruled out. Next. Ensure that woman has understood precautions and care needed during post-abortion period. There's opportunity to counsel for contraception in this follow-up visit if she has not agreed to use contraception after the abortion process, and you have to reinforce the need for continuity of the contraceptive method chosen. She just can't use it for 1 or 2 months. See to it, convince her that she has to continue with the contraception method which she has chosen. Next. Again, if when you are doing counseling post-procedure, again, you have to ensure the privacy and confidentiality. Reassure her in case she is having any problems after the procedure, and you have to repeat the information about post-procedure care and danger signs in this follow-up visit. Next. So if she has already opted for contraception, then do appreciate her. Then immediate care, if she has opted for IUCD, MPA, you can inject or you can insert it immediately. If she has opted for oral pills, tell her how it should be used and how she can use it as an ongoing method of contraception. Do emphasize and tell her about the follow-up protocol for that method-specific contraception, and there has to be a continuity in your follow-up visits and for that contraception method. But if she's undecided that whether to choose contraception or she should not use contraception, give her time and help her in deciding. But first you have to allay her anxiety that why she is so anxious about choosing a contraception method. You have to emphasize the importance of immediate adoption of the contraceptive method So do try to convince her that if she chooses immediately and starts using contraception immediately, it is good for her own health. Then, as far as possible, we have to do couple counseling. And if she's not willing for either oral pills or IUCDs, do tell her about the emergency contraception. Next. So if she has chosen barrier methods, then you have to tell her that as soon as sexual activity is resumed, she has to use these condoms. And the additional information you should give her that there are no hormonal side effects. This can be used without consulting a health provider, easily available everywhere. There is added advantage that it prevents against sexually transmitted infections, including HIV, if used correctly and consistently. And this enables man to take the responsibility of contraception. Next. If she has chosen IUCD, there are many types available, copper T, multi-load. If she has chosen this IUCD after first trimester abortion, then it can be inserted immediately or up to 12 days after confirmation of a completed abortion using the surgical method with MVA. It can be inserted around day 15 of the process, provided complete POC expulsion is confirmed and risk or presence of infection or any other contraindication is ruled out. If the abortion is a second trimester abortion, then IUCD can be inserted immediately or up to 12 days after the procedure is complete, and you have to rule out the contraindications before inserting IUCD. The additional information which you have to counsel and tell her is that this is a highly effective method of contraception. It provides long-term contraceptive up to the 5 to 10 years, can be provided by trained doctors, and A&M nurses can also provide IUCD services, and PP-IUCD can be inserted by PP-IUCD trained doctors. It does not interfere with the sex. There is immediate return to the fertility once you remove this IUCD, and there are no hormonal side effects. Next. If she has chosen to go ahead with a combined oral contraceptive pills, then if it is a first trimester abortion, you can start it immediately or up to 7 days after abortion. Using surgical method with MVA, it can be started 1 day on day 3 with the dose of misoprostol or within day 15 of the process after confirmation of complete abortion. If it is a second trimester abortion, you can start COC pills immediately or up to 7 days after abortion. The additional information which you have to provide to this woman is that she will have regular menstrual cycle with the COC pills. This can be provided by all health workers after first screening by a trained provider. So even if she is staying in rural areas, she will not have shortage of COC pills. She can approach the PSCs or any rural community center, and she can have access to combined oral contraceptive pills. This does not interfere with sex. Rather, it offers protection against ectopic pregnancy, endometrial and ovarian carcinoma, and benign diseases such as fibrocystic and fibroadenomatosis. But it is not suitable for women who are breastfeeding their babies when they are less than 6 months postpartum. Next. If she has opted for Mpa injections, then in cases of first trimester abortion, you can give it immediately or up to 7 days after abortion using surgical method, and with MVA, it can be started on day 3 with the dose of misoprostol. If it is second trimester abortion, it can be started immediately or up to day 7 after abortion. The additional information which should be provided with MPA is that it is highly effective. It maintains the confidentiality and privacy. This can be provided by doctors, A&M, nurses, and Ayush doctors. There is no interference with the sex. There is no effect on the quality and quantity of breast milk, no estrogenic side effects, and this offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. Next. If she has opted for permanent methods in the form of female sterilization, then after first trimester abortion, it can be performed after an abortion in the absence of any infection or severe blood loss concurrently or up to 7 days. Both mini-lap and lap sterilization can be done here. With MVA, it can be done only after the first menstrual cycle. If this is a second trimester abortion, then mini-lap sterilization can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Remember, lap sterilization is not recommended in case it is second trimester abortion. The additional information which should be provided with this method of contraception is that it is a permanent method of contraception, highly effective. It is effective immediately. It does not interfere with sex. There is no effect on breastfeeding, no long-term side effects, and this offers protection against ovarian cancer. If the couple has decided to go ahead with the vasectomy, then this can be performed independent of the timing and procedure of the abortion. And the additional information should be provided is that it is very effective, permanent method, does not interfere with sex, no long-term health risk, and couple must use another method of contraception for another 3 months or till the man becomes azoospermic. Next. Next. Shriman, next job. Yeah, this I have already explained. Yeah, next job. Now in this COVID era, everyone has learned the importance and benefits of teleconsultation. Next. So abortion services, the counseling services can be provided by teleconsultation, telecounseling, teleguidance. You can have telereference and telelinkage services can also be taken care of. Next. These are the techno IC. You can take help of website, the social media like we already have Ask Tanu. YouTube is a very good channel for the patients. Then infographics, you can take help of the helpline. And there are many patient education platforms available, that is of WHO. Even our own Ministry of Health and Family Welfare is having a patient education platform, and RCOG also provides these platforms. Next. So once we see the teleconsultation and once we do the SWOT analysis of teleconsultation, that is strength, weakness, opportunity, and threat. So let us first see the strength of teleconsultation. In this COVID era, we all know this has got many plus points as far as teleconsultation is concerned. It is, you can approach at each and every corner of India. It provides the confidentiality and the awareness, and patient can reach out to you. But the weakness is that you can't approach this woman face to face and you can't demonstrate how she can use that particular contraceptive method. But it provides the opportunity in the form of privacy and comfort, and it is cost cutting, and the number of visits are definitely cut down. But the threat with this teleconsultation is that you might miss some opportunities, and there is rarely a chance of misdiagnosis. Next. So you have to first confirm the diagnosis, then counsel her for the need of contraceptive, counsel her, and follow-up visits can be on teleconsultation, or it can be in the form of hybrid services. That is, first visit can be a physical one, and the later on visits can be on this digital platform. Next. So the key message for this talk on family planning counseling is that you have to realize the need of it. you have to bring the couple on board and strive for 100% coverage of contraception, capitalize on the basket which we have and the applicability in this post-abortion period. And you can take help of the technology as far as possible. And don't forget to provide adolescent reproductive health services, both online and offline, as it is the need of the hour. Next. Yeah, so thank you so much for your patient hearing. And to earn a certificate, you all have to fill the post-test and feedback form, so that certificate will come in your email inbox. Thank you once again.
Thank you so much, Dr. Lakshmi. I think that was quite a nice, comprehensive counseling module that we have, both the pre and the post. And it is so important, as you said, to offer it to everybody, including the adolescents, because they are the ones who are most likely to get into trouble. And I think you are right. We need to somehow make sure that these adolescents don't get into trouble and they are more free to come and talk to us. And it is the attitude of the doctors which would be the most important, because when we start being judgmental, the patients also tend to feel a little scared. So thank you once again. And thank you, Pratik, Amaya, Riddhi. Do you want to take over from now?
Thank you, Dr. Preeti Vyas, for doing the honors and being the chairperson for the second half of the program. If there are any questions from the audience, we can have them now. If there aren't any, then I would like to propose the formal vote of thanks. Does anybody have any questions? Please feel free to put them in the chat box and we'll try and address them.
Yeah, I think just tell everybody that the link has been put up in the chat box for the post-test questionnaire to be filled up. If you all can just later on click on it and do it.
All right, perfect. So I think we've had a very fantastic, engaging couple of hours, and as the convener, along with two other distinguished MOGS Managing Committee members, it's my duty to perform the official vote of thanks. I'd like to express my gratitude to the FOXI President, Dr. Shanta Kumari, Secretary General of FOXI, Dr. Madhuri Patel, the President of the Mumbai Society, Dr. Sarita Bhalera, Secretary of Mumbai Society, Dr. Suvarna Kadilkar. Thank you for giving us the permission and helping us to coordinate this MOGS FOXI Respectful Abortion Care CME. Thank you to Dr. Riddhi Desai for being the Master of Ceremonies, and to the chairpersons, Dr. Amay Purandare, Dr. Preeti Vyas. Thank you so much, Mr. Ajay Bharadwaj, for coordinating behind the scenes, and not only for this particular program, but for the entire series of events which are being conducted throughout the length and breadth of India, throughout even the smaller societies. I think this message needs to percolate through. We had three fantastic speakers, Dr. Krishna Kumari, Dr. Kiran Mai, and Dr. Lakshmi Shikhande, who addressed different aspects of respectful abortion care. All of us have been left enriched thanks to these speakers and to the standardized module which has now been put out. Thank you again for being here, spending your valuable time with us. And at the end, on behalf of my co-conveners, Dr. Amay Purandare and Dr. Komal Chavan, we express apologies on behalf of Dr. Niranjan Chavan, since he could not make it, but we could have a nice pre-recorded talk from Dr. Archana Sharma, which started the ball rolling. Thank you again for joining us. Looking forward to having you at the next event and requesting you to do the post-test questionnaire and earn your certificate. Thank you. Goodbye. God bless.
Thank you. Thank you all. Bye.
Bye.
Bye. Thank you.